I think we might get underway actually now. So welcome to the LEARN webinar. LEARN stands for Listening to the Experience of Participants on Neurosurgical Trials. And there are two studies that are linked together. There's LEARN GDNF and LEARN TransEuro. I wonder if we could go on to the next slide, please. Today, there are going to be contributions from me, Helen Matthews from Cure Parkinson's. Welcome to you all. It's lovely that you've been able to join us. We're then going to hear from Dr. Emma Lane and Dr. Cheney Drew, who've been driving this really important work. They're also going to introduce us to the range of resources that this project have produced. Leslie Gosden and Jane Calder, they're going to share their participant experiences. This work could not have happened without the wonderful and very generous contributions of every single participant who's shaped this work. So we're incredibly lucky to have both Leslie and Jane and Darren with us today. So thank you very, very much indeed. Dr. Alan Wone will be joining us a little bit later, so you'll see him pop up as well. And he's going to share the perspectives as the chief investigator. You then hear back from me as a funder. And then Emma and Cheney will wrap up with the future for these LEARN studies and the resources that have been developed as a result of that. So without further ado, I'd like to remind you, if you have any questions, please do put them in the Q&A. The Q&A button can be found at the bottom of your screen. If you just hover at the bottom of your screen, a Q&A bubble pops up. And we really look forward to hearing from you. And thank you so much for joining us. Emma, over to you.
Thank you so much, Helen, for introducing us, and thank you everyone for joining us today. It's an absolute pleasure to be here sharing with you the work that we've done as a team. And my first job really is to introduce you to the team, because it's by no means, as Helen alluded to, the work of one or two people on behalf of myself and Cheney, who co-lead the LEARN study team. I want to share with you the other contributors. We have Kim Smallman, Suzette Sharmoon and Carly Barawi, who are vital members of our team as we look to develop the study team together. And they've conducted these first two LEARN studies together, and we've got ongoing work which we'll allude to later on. But we are just the team that have done the work. We couldn't have done it similarly, as Jane has said, as Helen has said, without our other contributors. So just to give you an idea of what we have done and what we're planning to do as part of the LEARN study team. So our main focus is to try and understand what the experience is of a participant taking part in a clinical trial. And this is part of a bigger piece of work. And this slide shows you some of that broader aspects of the work that we're doing to try and understand what trial participants experience, but also to then try and understand what the barriers might be to facilitating trials for individuals, and also to then think about how we can try and break down those barriers or enable people to hurdle those barriers, so that we're opening up participation for all kinds of different trials to anyone who may wish to participate in them. And we've got different strands to this work. We've been looking through the literature to try and understand what experiences, what is reported, what is known of experiences of pharmacological or drug therapy trials, as well as advanced therapies. Advanced therapies are interventions like cell and gene therapy that are very much in development and in clinical trials currently for the management of Parkinson's disease. We've also worked with Cure Parkinson's to understand what the broader population of people living with Parkinson's disease have experienced, whether they have or haven't taken part in trials, to see whether we can again learn more from those experiences. But the focus of today's webinar is on some two specific pieces of work that we conducted sort of in parallel to try and understand the experiences of novel advanced therapies with the participants, with their wider support network, and also the experiences of the trial teams who ran those trials. I've got the names of those trials here. You can see them down the bottom here. So we've got the GDNF, TransEuro and STEM-PD trials. The STEM-PD trial is an ongoing clinical trial in cell transplantation therapy at the moment. So I'm not going to say anything about that particular piece of work because it's currently ongoing through a live clinical trial for cell transplantation in Parkinson's. But I am going to focus more on the GDNF and TransEuro studies. So just to explain a little bit more about what those studies were and what we have done around those clinical trials. GDNF is a protein that has long been explored as a potential protein that could try and support dying brain cells and try and help rejuvenate those cells to support their survival in the brain. And therefore they could be, this drug could be a very good intervention for the management of Parkinson's disease to try and stop the progression of the disease. The challenge with the protein is it's very difficult to get it into the brain. So in the clinical trials, it was delivered directly through a port that was surgically implanted, and cannulae or tubes were implanted directly into the brains of the participants, and they attended then the clinical facility regularly, monthly, for infusions of this protein directly into their brains. So this is quite a significant undertaking for those participants, and some of you may have seen documentaries about the experience of those participants and about the trial in itself. It was such an innovative trial that there was a huge amount of interest in it. TransEuro is another clinical trial, which in this instance was about the direct transplantation of cells into the brains of people with Parkinson's disease. So quite different from the GDNF trial, but one of the common threads of that is that this was a new study. It was a new approach, but also that involved invasive brain surgery. It involved putting something directly into the brain, and it also was quite a big undertaking for the participants. So both of these trials have required quite significant commitments from the participants and have been very involved. And so the goal for us was, in working with a group of people who had been part of the GDNF trial, we developed a structure to try and understand how participants had experienced these trials. And you can see our structure on the side here. So we convened as the Learn Study team, and I have to say that we are a multidisciplinary team brought together hopefully with the expertise that will allow us to address all the different aspects of this study. We have lots of different backgrounds that we come together to create this team, but we couldn't do this without having input from those who'd already participated, who shared some of their experiences with us early on. And that was our participant consultation group, and that involved participants but also people who'd supported those participants to allow us to structure interview guides so that we could then interview a wide number of people who'd taken part in that trial and their support partners, and also use that to interview the TransEuro participants to try and understand what their experiences were. To make sure that the outputs were as broad as possible and to gain lots of additional input, we also had an advisory group made up of individuals who contribute to research ethics committees across the United Kingdom, and they approve clinical trials from an ethics point of view. So often see resources or require training to understand what those trials may involve, and are also now trying to listen far more to the patient voice than they have previously. We also had an independent advisory group made up of a range of stakeholders, from neurosurgeons, neurologists, and people with Parkinson's who hadn't taken part in the trial, to steer what we were doing. We conducted a series of interviews of participants through these trials, and we're incredibly grateful for the time that every participant of our trials took in giving us a lot of their thoughts and their experiences and sharing those with us. What we did was then work through trying to identify what the key learnings might be. We identified various issues, and then from those we have sought to create some resources that perhaps can be used going forward by those running future clinical trials to support individuals to overcome some of the barriers that we identified to trial participation. So I'm going to hand over to Cheney now, who is going to talk you through our key findings and the resources that we've created.
Thank you, Emma. I'm going to do my best Chris Whitty impression. There we go, next slide. So the first resource that we want to talk about, and the first finding, was really about how can we ensure that a potential participant for a trial, knows everything that they need to know. And we keep coming up with this phrase of, how do you know what you don't know? So we've created a checklist for participants that they can use as this says, in their own time, to really look at all the different aspects of what taking part in a trial might mean for them. And it allows people to ask questions of those people recruiting them into trials. It also allows their support network to look at all the various aspects of the trials as well. And this short 30-second video is just a social, we call them the social clips, introducing that checklist. I think Emma's going to play that now. Is the sound not working?
Apologies, I was on mute, so you couldn't hear anything.
Okay.
Clinical trials in Parkinson's disease can be very varied. Whatever the trial looks like, there may be lots of different components that participants need to consider before they take part in a trial. We spoke to charities and we spoke to participants in trials to understand what might come together to create a checklist. The checklist is divided into sections. Each section is prefaced with some guidance about why you might want to ask these questions. You can reflect on those in your own time to make an informed decision about whether you want to take part in this clinical trial.
Great, thank you. So here it is in document format. This is not, I have to say, the finished document. We're still working on some of the formatting, but this gives you an introduction as to sort of the types of questions that might include, and it'll be freely available on various hosting websites, which we'll talk about right at the end. If we move on to the next one. One of the other key findings was the challenges that participants faced around brain imaging. Now, it's important to say this wasn't a problem for all participants, but where some people did find that they had issues with going into an MRI or a PET scanner for a significant length of time, the problems were not insignificant. And so we've created a short guide around what you might expect if you're asked to take part in a trial that includes MRI and PET imaging. And this video here introduces what that process will look like for you.
In a clinical trial of a new treatment, we need to measure different things before, during, and after. Trials of neurodegenerative diseases like Parkinson's or Huntington's may involve looking at what is happening inside the brain itself. We need to determine whether the disease or a new treatment is affecting the structure or function of the brain. There are several tools that can help us do this. This includes magnetic resonance imaging, or MRI, and positron emission tomography scanning, or PET. For any kind of brain scan, it's important to feel comfortable. So wear loose, comfortable clothing with no jewelry, belts, or other metallic objects. An MRI uses a strong magnetic field to take pictures of the structure of your brain. Due to the use of magnets, it's important you go through a safety assessment before you proceed with the scan to make sure you're a suitable candidate for MRI. Next, you'll be asked to lie on a bed, and your head position will be stabilized to limit head movement. It's essential to keep as still as possible in order to get a clear picture of your brain.
There we go. So we're not going to show the whole video just because it's 3 minutes long and in the interest of time. But what you can see there, whilst we've got Emma's wonderful voiceover, we do have videos. All of our videos will be released with Welsh subtitles as well. And we hope that further down the line, if other subtitles are required, we can easily change those subtitles over. So that's something that we'll be able to do. So in the third of the key findings that came out of the interviews was around the challenges of off assessments. So where people are asked to come in and have their disease symptoms measured, but off their medication. Again, this was, for some people, this was the first time that they'd experienced sort of a real off period and not just a fluctuation. And that was quite distressing for some people. But again, even though the first occasion was difficult, participants soon learned how to deal with that scenario, and so we've been able to use that information again to produce some guidance. And I think we're just going to flick to the introduction.
When we ask people to take part in clinical trials, sometimes there's a need to evaluate and assess individuals without their medication, and that's an assessment in what we call OFF.
It's quite a shock the first time you go off, because you don't know how bad your symptoms have got because they're controlled by the medication. You do experience being off, but not quite as badly as when you go for the trial. And I knew I had to go through it because it's the only way they can see what my symptoms are like. On medication, like now, they're shielded. You don't see the full brunt of what happens when I'm off medication.
For more guidance around OFF assessments and how to manage them, we have produced a short guide. To find out more, contact us on the Learn Study email address.
And again, we have an accompanying document that has written guidance for what you can do if you're asked to take part in a trial where you are asked to do an OFF assessment. And then I think this is the last one. One thing that became hugely apparent as we were conducting the interviews was that a participant is not alone in taking part in a trial, and it really involves their support partner and their wider support network. And so we have also produced a video of support partners in conversation, where some of the sort of trials and tribulations of being that support partner and how it affects you as a supporter of that person taking part in the clinical trial. And I'm about to say why Emma plays this. The best thing about all of these introductory ones is that I'm not in them, which is brilliant. I hate seeing my own face.
What would you want other families of those with Parkinson's to know before taking part in a trial?
Keep an open mind is what I would suggest. Do as much research as you possibly can.
I think the more you allow yourselves to be as open and honest as possible, the more you go through this illness as a partnership. And I think partnership is probably going to be the best way of making any decision.
Great, thank you. And just to highlight again that these short introductory videos that we've just shown you now are small clips, and we will be releasing the fuller sort of 3-minute videos shortly. And just as a final thank you from me, you will see here some familiar faces on the panel that were included in those videos, and a massive thank you to Leslie, Colin, Darren and Jane for coming and filming with us and providing their time and their energy and enthusiasm in developing those resources. So thank you. And now I'm going to hand over to Jane and Leslie.
Hi Leslie, would you like to go first?
We can't hear you, Leslie.
Is that better?
There we go, we've got you now. Thank you.
Change microphone. Yes, I said forgive me for reading from a prepared script, but my ability to ad lib is diminishing. The Bristol GDNF trial was one of the most invasive trials into Parkinson's. The effects of participation were profound and life-changing. The whole experience was at the time surreal, occasionally terrifying, but always satisfying. We were breaking new ground, so learning from those at the hub is essential. A trial that does not meet its primary endpoint still provides vital information about a specific condition, and it's important to gather as much detail about the patient experience in order to inform future research and improve trial design. The Learn study was set up to seek feedback from the participants, how we felt about the trial, how we coped with the heavy commitment, what we would do differently, and so much more. The Learn team interviewed participants about their experience before, during, and after the trial, but importantly, they also included family members and carers, as taking part in this trial required the support and understanding of those closest to us. This was not for the faint-hearted, but knowing that my family were behind me all the way kept me going. Carers also have a different perspective from the patient, but their insight and personal knowledge of the participant is unique. The Learn team dug deep into the Bristol experience and have embraced patient involvement enthusiastically. They consulted with participants on areas to cover and asked open questions, allowing interviewees to expand on their responses rather than requiring tick box answers which are too prescriptive and fail to capture the essence of Parkinson's. Their exploration into the physical and mental effects on volunteers and their families meant that interviews became very emotional, but experiences were shared in detail and with complete honesty. The study has highlighted many issues that need resolution before further trials are designed. For example, preparing participants for going off medication and the provision of care once the trial is over, plus much more. The series of videos they have produced are a step in the right direction to better prepare volunteers for taking part in research and to consent with their eyes open wide. They've worked tirelessly at all times, including the patients, to gain an in-depth understanding of taking part in research. It's been a pleasure to work alongside Emma and Cheney. Their enthusiasm and drive is refreshing and reassuring. There is a chasm between the scientific approach to clinical trials and that of the volunteers who simply want to improve quality of life. The work carried out by the LEARN study is a major step forward in raising awareness of the needs of patient volunteers and their carers and bridging this gap. Over to you, Jane.
You're on mute, Jane.
Apologies, sorry about that, guys. So mine is really the support partners perspective. So for me, it's not really a surprise that the biggest thing to come out of the LEARN study is actually the learning from every stakeholder's perspective. The wording support partner really speaks volumes about the role that is crucial to support the person that is actually taking part in that trial. If you go it alone, the person with Parkinson's, if they go it alone, they're not going to capture everything. Sometimes I actually think they hear what they want to hear, and then being able to communicate that back to their families can be very, very difficult because they've not been able to retain to then be able to explain. From pre-trial interviews, during the trial, post the trial especially, and then transitioning back into the real world, the support partner can be enabled to capture observations that the person with Parkinson's may not be able to translate into words, to explain the way that they're feeling. And then, you know, all of that information, if you pull it from the care, the support partner, it can actually contribute to the trial findings. We just need to know that we're asking the right questions. The checklist, if we'd had a checklist, it would have just given me as a partner a masterclass. It would have helped me find the answers to questions I didn't even know. And then thinking back to the reality, the family were asking me to explain because Darren wasn't able to explain, and actually a lot of it I hadn't asked the right questions in the first place. So this checklist kind of includes a huge amount. You may not want to know the answers to some of the questions, but you can turn to it and make decisions for yourself. And I think it's a great piece of work that has been done. I'm very grateful. The support partners video is really excellent. Darren and I always say, you know, it's not just Darren that has Parkinson's, it is a partnership, both of you having to work through the Parkinson's together. And it really does give you great insight into the support partners' thoughts and views as they traverse through the emotions of a supporter. Because emotionally, it really did have a huge effect on us, the GDNF trial. Remembering that a trial is there to work towards developing a potential treatment is key in terms of keeping perspective. And so from, you know, a lot of support partner feedback that I've received, it's important to be reassured around improving a couple of things really. So communications, even when there's nothing to communicate, to just be able to say, we'll stay in touch, but you know, we're here, but there's nothing new. Managing the expectations of the person with Parkinson's and their support network continuously, because they're looking for that. is really important. And then having complete transparency, and it goes back to this whole partnership being, when you enter into this, you really do feel that you are a partner. So it's just ensuring that we encapsulate all of that. I truly do believe that the Learn study has done an outstanding job of delivering a toolkit to improve the journey from start to finish, and indeed beyond that, for better care for all who embark on these challenging adventures, really, because we're all looking for the cure for Parkinson's, and we can't find that cure without contributing to research. Thank you.
Thank you so much, Leslie, Colin, Jane and Darren, for your contributions throughout this project. It wouldn't have been possible without you, and those words mean a huge amount to myself and Cheney as well. But another person we couldn't have done this without is also Dr. Alan Wone, who has been very open with us and also been part of the study and shared his experiences. So we'd like to, and we're very grateful for you allowing us some of your time today, if you'd be able to share some of your thoughts, Alan.
So the things that I thought, and I was making notes as you went through, I'd reflect on. So the first thing is, was it worth it? And perhaps we could have done better at emphasising after Pfizer pulled out why it was worth it, although perhaps people were too devastated at that point to hear it. So firstly, on a scientific basis, I think it's worth it because although, for example, deep brain stimulation is advancing, and therefore there are increasing ways of improving movement fluctuations through the day, not only with advanced DBS, but also inhaled L-DOPA is coming through or available elsewhere, sublingual apomorphine. There's a new formulation of long-acting L-DOPA. So there are some medication advances and so on, so we can improve symptoms. But of course, as you know, people get worse with time. So I don't think there's any question that disease-modifying or disease-slowing studies are worth it. And the neuroprotective studies that are being done, for example, the ones that were pivotally sponsored by CP with, for example, the diabetes drug exenatide, I think realistically, you might hope for at best a 30% slowing, which would be great and not trivial. I think the problem is if you get early onset Parkinson's, slowing by 30% is good, but it's not enough. And probably what's going to be required is a neurorestorative therapy to treat the movement symptoms, a bit like we treat DBS, but that continues to prove beneficial over time rather than people getting worse movement-wise over time as they do post-DBS. So getting people back to a good level of movement and then holding them there longer term with the restorative therapy like GDNF or cells, which I believe you'll be talking about a bit further, Emma. And then in addition, taking a protective agent to help as well, and you might be on several of the repurposed drugs, and particularly to be aware that we didn't find, and I don't believe anyone's found, robust evidence or any evidence really that the restorative therapies, those therapies given by surgery, are helpful for non-movement symptoms of Parkinson's. So if you continue to be able to move well but start to have memory and thinking problems, then that's difficult. So I think probably a combined approach, but I think that restorative therapies are still definitely worth going for. And then the things that came out of the study that I think are very important. So one was that Tom called me when he tried to convince me to go with the TV program. And he said he thought in the end the television program might be the most worthwhile thing to come out of this. So for those in the audience that didn't see it, there was a 2-part program on the BBC that broadcast over 2 weeks, each an hour long. And I think it was pretty well universally received as informing not only of Parkinson's and increasing Parkinson's awareness, but informing of what it means to be a participant in a complex study, and what it means to be in a study that then finishes when the participants believe the drug's working and they can no longer have it. So I think that was good. And in fact, it went on and won the Grierson Award, which is the highest award for documentary filmmaking. And it was the science documentary of 2019, which is pretty impressive. Although in second place was Landfill. So if we hadn't beaten Landfill, it might have been a bit depressing. But anyway, the programme was very good. So that's one thing. Then, of course, there's all the stuff that's come out of the LEARN study, which will certainly benefit surgical studies of Parkinson's with restorative agents in the future, given there are other ones currently in setup of viral vector study or cell-based studies. So this piece of work will inform that, and I think is critical. So thank you to everyone who took part in it and indeed conducted it. And I didn't have anything to do with the LEARN study other than to offer my insights, which I think was important because I'd be biased. Then another thing that came out was the device itself. So although we're not able to do another Parkinson's study at the moment, the device that's was used with the port behind the ear is now being marketed, at least in part, by Renishaw, and will be useful for other types of treatments, including cancer, I would have thought. So there was a lot about learning about direct administration to drugs in the brain that otherwise wouldn't be able to get to target areas, and it may potentially become a treatment for brain tumours in the first instance, which would be great because there's no treatment available currently for this, no cure. And then there's the PET data, and I'll come back to the PET and why it was so important that people suffered that. Then there was the PET data, which was the first time ever that it's been shown that you could distribute a drug across the whole part of the brain that you wanted to, the putamen in Parkinson's. So that was very important, and I think people would not have believed that without. So the problem is, given that our clinical results were didn't reach their endpoints, if we hadn't done the PET, we wouldn't have known where we were. We wouldn't have known whether it was a delivery problem of the drug, or whether it was a problem with the drug per se, or there were no dopamine nerve endings to rescue. And that's one of the questions that people have, and it was and well is a burning question, is by the time you're 8 years into your Parkinson's, which the average person was since diagnosis in the GDNF study, are there any dopamine nerve endings left to sprout? And the answer from the PET study is there are. So it refutes that. So it means that people with mid-stage Parkinson's could very reasonably be recruited into PD studies of this type in the future, and not just people newly diagnosed. So the PET data was important both for showing that dopamine nerve endings can be resprouted and for showing that you got good distribution. And it was the first study of that type with convection enhanced delivery, and that was replicated in the viral vector study. But those two studies together, the viral vector study that was done in the US, are very important. And then another piece of thing that's come through and was published this year was that the people in the GDNF study began to show dyskinesia, these involuntary type movements, when they were off their medication for 24 hours, which would be hard to explain other than those nerves had not only sprouted, but were able to release dopamine again, which is something that hasn't been shown before. And it's after the fact, if you like, in the sense the trial had finished, you see this, which more limits the weight you can put on the evidence, but it at least gives a suggestion that at least in some people, not only can you sprout nerve endings, but they can begin to release dopamine, if only to cause a side effect, which is dyskinesia. So that's important as well, that those nerves are beginning to function again in a normal physiological way. The question then is, how do you prove it? So I think it did give more information, along with various other studies, that the current outcome measures, including the UPDRS, are not good enough. And Jane and Darren, I do remember, I can't remember, Leslie, did you take part in the PD census study, the one where you live in the house?
Yes, we went down.
Brilliant. Okay, so hot off the press. So that study with in-home sensing was one of the first to be done of that type, and certainly over a week. And that data that you contributed to, along with wearable data, which is what Lynn Rochester, who's a world leader in that, does in Newcastle. Those two studies, so the one you did and all of the stuff the Newcastle group did, which is more extensive with Fitbit type devices, was put into a grant called Taurus, which Helen has been involved very much with supporting letters and so on. And part of the earlier study was paid for by CP. Anyway, that grant got awarded the other week, which gives us the small sum of £7 million, which I'm hoping for at least a car out of that. So, so that you know, it's a big part. So the whole reason I went and talked to the people in town about using their house was that lots of other people have recognised it as well, of course, but particularly poignant to me was that the outcome measures aren't good enough, and that's why I went to talk to them about the PD census study, and we conceived that study. So that drive for me to go and have that conversation has resulted in £7 million from the government now going into Parkinson's research. So, and you're taking part in it. And it was only a relatively small number of people who took part in it. I think 12 couples.
That's fantastic to hear, Alan. I think we've got to, huge congratulations on that. It's amazing to hear the positive things that are moving out of this study. Have you got any kind of final thoughts before we move on to Helen?
Good. Yeah, so in terms of the things that I think that you very nicely talked about, so the things that we need to do better in the future, the consenting, I think everyone did have about 2 hours of consenting before they signed. But Vicky Dillon was very good when she spoke at WPC in Japan last time, in the sense that she said, you know, she gave consent, she understood that she was giving informed consent, but at the same time, she felt that her Parkinson's meant she was looking down the barrel of a gun. So can you really consent in the sense there's that much pressure upon you? So there are things about how you could do that. I think one of the things MedGenesis, so I thought they were quite good actually, the support they provided through the study, but one of the things that, as Helen pointed out, at the end of the study was they didn't really have a plan B. So when the study was not immediately funded by Pfizer, they didn't have anywhere else to go. And I think that was because they genuinely thought if it was negative, they'd stop, and if it was positive, they'd go, but they hadn't. There are shades of negative, and I think they probably needed to plan for the aftermath, a bit more like the Gulf War, not just getting to the end of the study. I think it was extremely unfortunate that Pfizer didn't give an answer for a long time, and I don't know how we could have avoided that. But I think next time you'd probably want to find some way of having a hard stop. How you do that when there's commercial companies sort of dangling a carrot's difficult. Then there's the devices. So I'm definite that we should have taken the devices out at the end, although I think the advice that people could keep them in, and that might be better given the risks of surgery of taking them out, was reasonable advice. And in fact, one of the last people to have it out did have a surgical complication, which was serious, with a bleed in the brain. So I think it is difficult to know which way to go, but my own view is that we should just take them all out. Then there's the communication afterwards. So I think it was difficult because one of the difficulties is if you know what the end point is, you wouldn't take decisions. So because Pfizer kept saying, well, you'll know next month, you then just roll on. and then they say, you know, next month, whereas we might have done something differently if they'd said we're going to take 6 months, but you don't know that. So you keep taking iterative steps. But I think it would have been better, we could have communicated better if we'd sent a letter at the end of every month.
Perhaps I can use that as a great opportunity to bring Helen in to comment, then, because this kind of speaks to the role of where the trial is being led from and where the funder is. Thank you so much, Alan, for your comments. To bring you into the conversation, Helen.
Alan, I think your feedback into this meeting has been really, really powerful and really important, because although Learn has covered a number of aspects of this, I think there are a number of points that we haven't picked up on yet as the feedback from GDNF, and I think there is value in perhaps having a roundtable and bringing some of those thoughts together, and perhaps even creating a paper around lessons learnt and what could be done better. And actually your point about working with industry and actually putting a break clause in if a company is taking an option, for example, on a biotech, putting a break clause in there which has got a time constraint to it feels really, really, really important, because that for me was one of the biggest issues that we faced. But I do think that these Learn studies, there is more that still needs to come through as a result of all of this. We've done chapter 1, which is to develop some practical guidance that really can make a massive difference to other trials as they're being designed and developed. And I am thinking about, particularly some of the stem cell trials, and the pipeline of that is rich and very fertile territory to embed these resources into. But I think that there are other surgical trials as well that will be coming through. And it's absolutely vital that the resources that everyone's taken the time and the energy and the inspiration to create really need to be embedded into that. Emma, I know that you're going to touch on this a little bit later, but perhaps I can also say, as a funder of this work, we were absolutely clear that we wanted to learn as much as we possibly could, because we have to find a cure for Parkinson's. It is going to involve complicated trials. We have to involve difficult endpoints from time to time, but how we communicate those endpoints and how we deliver those endpoints with people with Parkinson's becomes really important. So, we've really learned from the imaging, for example, and guides will be created to enable those who are driving the imaging machines to make a better job of it for the participants who have to endure that. But also thinking about off assessments, what can we do around that? All of these are key outputs that really will make a difference to every trial, regardless of what they are investigating. And I think now we need to get down to some of the more specifics that are coming out from the Learn studies and the Learn projects themselves, and see where we can go with that. I did also want to say I'm hugely grateful to the study team, but also to all the participants who've contributed so generously to make this work move forward. I think it really is a wonderful thing. I also think that it is our job now to make sure that the outputs get embedded as far and wide as we possibly can. And with that, we've already started to embed them into the WPC Clinical Research Toolkit. I'm already starting to have discussions with things like the Parkinson's Clinical Studies Group here in the UK, but also in the US, to make sure that they are aware of this resource bank so that they can draw on them when there are complex studies that are calling on their teams to get involved. So that means that these resources will be used at the design phase, and that is critical, absolutely critical. Emma, I'm going to hang back to you. Actually, just before I do, can I just do this again? Alan, really fantastic news about Taurus. That really is wonderful. That could transform the way that we're able to deliver endpoints at home. And that really is fantastic news, really fantastic news. Emma, over to you.
Thank you so much, and thank you everyone. I'm going to reshare, just to pick up on what Helen was saying, is for anyone who's interested, these resources that we've created will be available. We're looking at continuing to look at how we can ensure that these resources that we've made so far are made available. So please, our email address is on the bottom of the screen. Please do email us. for any short-term requirements for the checklist for the off assessments. The videos will be hosted on a YouTube channel as well as on eurogct.com, and we're working with EuroGCT, which is a Horizon 2020 project focusing on the delivery of cell and gene therapies across a whole range of disease areas to ensure that members of the public have as much understanding and knowledge as possible before embarking on cell and gene therapies, as well as Helen said, in the clinical research toolkit. But this is very much not the end for us and for the Learn Study team. We are keen to maximise the impact from these studies. We have skimmed the resources, skimmed the information that we have to create these resources we felt the kind of most the highest need, but we know that there is still a lot more data in there, and what's been mentioned is the end of study quite frequently as an experience that we need to better support. And we have lots of evidence to support that, and we have lots of ideas about how we might be able to better support that we'll be seeking to try and establish and put in the public domain, because there's certainly a lot of evidence about the requirement to support participants to transition back into being a patient again, but also what that might look like for cell and gene therapies, where that transition is a lot more blurry because you don't just stop taking the medicine, you've had something put into your brain. We've created some partnerships as a course of this project. We're working with Prepare, who are a group based in Denmark and in Australia as part of the Novo Nordisk funded Renew Foundation, to try and look at how we can make more creative elements from this so that we can share the work and the efforts that have been put in by all of the participants to these studies and ensure that we can really maximise impact from them. I mentioned the STEM-PD study, where we're currently trying to understand experiences as people go through a live trial. And this is a transplant study that's taking place with Swedish and UK participants currently based in Sweden. The transplants are happening in Sweden, and we're working with the Swedish team and also with the UK team to ensure that we capture people's experiences within that trial, but also trying to understand more widely in the Parkinson's community and beyond the Parkinson's community what cell and gene therapy beliefs there are and what we might need to address to ensure that everybody gets access to firstly trials and then therapies in the future, and going beyond Parkinson's disease. We know that many of these therapies are being developed particularly for rare disorders, and again in those communities we need to make sure that the trials are designed for them and that their experiences are listened to as part of that trial process, because cell and gene therapy, these advanced therapies, move us into a whole new world of therapeutics that's being experienced in cancer treatment at the moment in some places, but we're moving that into the area of neurology. Just to wrap this up, I want to say an enormous thank you to everyone who's contributed to the webinar today. It's been incredible hearing from all of you. We're very grateful for your time and your contributions, even more so because you've participated in the study and your contributions to that were amazing. And the honesty and openness that everyone had in sharing their thoughts and feelings with us certainly did lead to some emotional moments within those interviews. But the learnings are so incredibly valuable that we want to make sure that those learnings are blended with those learnings that Alan and Helen have gained from their perspectives, so that we can work together to ensure that future trials place the patient more at the centre where practical, where we listen, where we try and overcome obstacles and barriers together to produce really robust, solid science and solid clinical trials that have that evidence base, but that also bring the participant along and give them the best possible journey on that. The GDNF and TransEuro clinical teams have been fantastic in being open with us, and our advisory groups gave us insights that and ideas and thoughts that we wouldn't have generated on our own, so they've been incredible. We're hugely grateful to our funders and collaborators, Cure Parkinson's and Parkinson's UK funded Learn GDNF and Learn TransEuro, and we're working with Michael J. Fox on the STEM-PD study. Storm and Shelter produced the videos for us, and they were incredibly patient with our naivety about how we might go about producing such things, and were very good at fitting around our timescales, and they were hugely accommodating. But I think the last thing for me to say is that anyone who takes part in a clinical trial deserves our thanks. We can't progress understanding new therapies and new treatments without anyone who takes part in a trial. And we're hoping that we can try and improve those experiences and make those opportunities available for anyone who wishes them. So with that, I think we'll move to the Q&A session.
Yeah, I think
any questions.
Yeah, so we have one here from Andy Rowland about whether or not the resources have been used in any trials yet or are online to be used, and if so, what feedback we have received. Hopefully, Andy, we've already answered that for you. This is sort of a quick preview launch for all of our collaborators, participants, and advisory groups. We'll be launching them officially at WPC. At which point they'll be hosted in all those places that Emma just listed. And we are very aware that we need to be monitoring feedback and impact of what these resources mean to people with Parkinson's who are asked to take part in clinical trials, and particularly more advanced for advanced therapies. So we will be keeping an eye on that, and I'm sure we'll keep everyone updated as to the kind of feedback that we get.
I think just to add to that, Tony, we've had fantastic support, not just support, but close relationships with their funders. So with Cure Parkinson's, Parkinson's UK, and Michael J. Fox, and they're also in a position to support that partnership with us and with trials as they run, to support us to embed those and monitor them and feedback to us if they need changing, addressing, amending, revisiting for their utility.
Yeah. And then we have a question from Guy about what if a participant does not have an obvious care partner. That's a slightly trickier question. It depends on the type of trial and how involved that trial is, and what type of burden we think that trial might have upon the participant. For most people, you don't require a support partner to take part in a clinical trial. It's now becoming something that is now included in inclusion-exclusion criteria, where it's felt that it would be deleterious to a participant's well-being to take part if they don't have any support in place. As we learned with the interviews that we provided that we did with the GDNF participants, although there was no requirement for a support partner, and some people were very adamant about taking part, even though their loved ones had said, we won't support you in this because we don't necessarily agree with you taking part in it, they were okay in taking part, but it would have made a difference to them to have a support partner there. So it's really finding out where support partners may or may not be needed. And I think that's something that now needs to be explored in terms of making sure that everyone has equitable access to these types of trials and these types of therapies. If someone doesn't have a support partner on hand, how do we manage support for that participant so that they can take part in that trial? So that we shouldn't exclude them because they don't have a support person on hand, but it's then on us as trialists and researchers to make sure that their well-being is cared for if they're going to take part in the trial. And I think that's about it for questions, unless anyone else had another question to ask.